Today I'm going to discuss about an important topic, which is the how to localize a brainstem lesion. The most useful technique to localize a brainstem lesion is the brainstem rule of 4. This is a technique which I've used for last 10 years, and the success for localization is amazing. It's more than 95-96%. You can easily localize in patients who are presenting with brainstem. Now, what I'm going to discuss today is about basic structure of the brainstem, what is the rule of 4, and how we use the meridian to locate the brainstem lesion. Now, if we look at the brainstem structure, there are three main components. One are the long tracts. The second is the cranial nerve nucleus, and whatever left is the reticular formation. For the purpose of this discussion, we don't need to know about the reticular formation, since I'm not going to discuss anything about it. Now, regarding long tracts, the important long tracts we can divide into either tracts which are coming down from the cortex and going down. There are important long tracts which are present both medially as well as laterally, and there are sensory tracts again that can be structured. Some are present medially and some are present laterally. For example, the important long tracts which are present medially are: one is the motor tract, which is the corticospinal tract, which is present medially. And then there are other two important tracts which are present medially, which include the motor tracts, which is the corticospinal tract, and then we have got medially the important motor sensory long tracts, which include the medial lemniscus, which is carrying the fine touch, vibration, proprioception sensation from the periphery on the opposite side, and also medial longitudinal fasciculus, which is connecting tract between the third, fourth, and sixth. This is particularly important if we think about the gaze movement of the eye, where the coordination between one side to other, third, fourth, and sixth, is done by this medial longitudinal fasciculus. Now, regarding the cranial nucleus, it can be divided into three groups. One is the somatomotor nucleus, which includes 3, 4, 6, and 12, or we can remember as multiple of 12. Then there is somatosensory nucleus, which is the sensory nucleus of trigeminal. The sensory nucleus of trigeminal is a long nucleus which is present throughout the brainstem, and it is important to understand this nucleus which is present throughout the brainstem. It is divided into three parts. One is the one which is present in the midbrain, is called mesencephalic nucleus of trigeminal. One which is present in the pons is called the principal sensory nucleus of trigeminal, and one which is present in the medulla is called the sensory nucleus of trigeminal, or which is called the spinal nucleus of trigeminal, because although it's present in medulla, it also spread up to the spinal cord, so it is called the spinal nucleus of trigeminal. Now, another important point regarding this nucleus: all the proprioceptive information from face comes to the mesencephalic nucleus of trigeminal. All the fine touch sensation come to the principal sensory nucleus, and all the pain and temperature sense comes to the spinal nucleus of trigeminal. So, depending on which part of the brainstem this nucleus is affected, it has got localizing value. For example, If the principal sensory nucleus of trigeminal is affected, which is present in the pons, we can get dissociated anesthesia with intact pain, temperature, and proprioception, whereas the fine touch might be only affected on one side of the face. On the side of the nucleus, there will be sensory impairment of the fine touch in the face. The other important nucleus, which are the visceromotor nucleus, which is the 5th, 7th, 9th, 10th, and 11th, out of which 5th and 7th is present. 5th and 7th is present in pons, and 9, 10, 11 is present in the medulla. I forgot to add another nucleus here, which is what mentioned, special sensory nucleus, which is the 8th cranial nerve, which is again present laterally only in pons. So this is the basic structure of the brainstem. Now there are 4 rules which govern the brainstem localization. Number 1, there are 4 midline structures beginning with M. So if we we'll come to that. There are 4 lateral structures which begins with S, and there are 4 cranial nerves in the medulla, as we have said, 9, 10, 11, 12. 4 cranial nerves in pons, which include 5, 6, 7, 8, and there are 4 cranial nerves which are present above the pons. So there are 2 cranial nerves in midbrain, 3rd present in the upper part of the midbrain, 4th in the lower part of the midbrain. 1st and 2nd is present in the cortex, so that is not part of the brainstem. And meridians of longitude and latitude. So like when we try to localize a point in map, we use longitude and we use latitude. Now in brainstem, we will use the same concept. How? The longitudes will be the long tract signs, or whereas the latitude would be the cranial nerve nucleus, whereas the longitude would be the long tracts. So if we go to this picture, we can see that the latitude in the map would be this cranial nerve nucleus. Out of this cranial nerve nucleus, there are certain cranial nerves which are present medially. For example, one of the 4M. So the somatomotor cranial nerve nucleus which are present medially include 3, 4, 6, and 12, which are the multiple of 12. And then there are other cranial nerves, all of which are present laterally. 5, 6, 7, 8, 9, 10, 11. But one thing worth mentioning, out of this, the sensory nucleus of trigeminal has got specific localizing value depending on which part it is affected, as it is present throughout the brainstem. So depending on which part is affected, they will have dissociated sensory loss in the face. And then there are other long tracts which are present medially, which include the medial longitudinal fasciculus, which connects between 3rd, 4th, and 6th. There is corticospinal tract or motor pathway, which carries the corticospinal fiber from the cortex up to the periphery, and also corticobulbar tract as well. And last but not the least, the medial structure, the long tract, is the medial lemniscus, which carries pain, which carries, sorry, not pain, which carries fine touch proprioception vibration from opposite side of the periphery. So if we take the four medial structures, so these include the motor nucleus 3, 4, 6, 12 and MLF, motor pathway, and medial lemniscus. Now if we go to the lateral structures, out of which the important long tracts are spinal lemniscus, which carries pain temperature from the opposite side in the periphery and the trunk. So for example, the left spinal lemniscus in the brainstem will carry information from right upper limb, right lower limb, and also on the trunk. Then there is sympathetic outflow, which is a motor outflow from the sympathetic which is coming from the hypothalamus and is going to the periphery to control the sympathetic nervous system. And last but not the least, the sensory pathway, spinocerebellar tract, which carries information from the periphery up to the cerebellum. So these are the three long tracts which are present laterally, and all the other cranial nerves except 3, 4, 6, 12 are present laterally as well. So now if we know this, we can deduce. For example, if I ask you that patient has got third nerve palsy, patient has got third nerve palsy on right side and weakness of limbs on left side. So where is the problem? So this is a cross symptom, third nerve palsy on the right side and weakness of the limbs on the left side involving both upper limb and lower limb. So now if we use this rule, so cranial nerve is the latitude, which is third and which is present in the midbrain. So it would be a midbrain lesion. Now is it a medial or lateral cranial nerve? This is a medial cranial nerve. So not only we know that it's in the midbrain, it's a medial structure. On the other hand, if we take the long tracts, the motor tract, which is again a medial structure. So the diagnosis in this patient is medial midbrain syndrome. Let's try another problem. Patient has got number one, patient has got loss of pain and temperature on left side of face. Patient has got also loss of pain and temperature on right side of both upper limb and lower limb. Horn nuts, patient has got horn nuts on left eye. Patient has got swallowing problem. Patient has got dysphagia and patient has got cerebellar signs, motor signs like dysdiadochinesia, dysmetria on left upper limb plus left lower limb. So where is the problem? Now, if we look at the cranial nerves which are affected, they are sensory nucleus of trigeminal, that is fifth. It is also 9th and 10th because patient has got dysphagia. So where is so if we take into cranial nerve, two things we can deduce from here. So one, which part of the brainstem it is affected? It's medulla. And is it medial or lateral part of the medulla? This is lateral part of the medulla. And if we take the long tracts, so if there is loss of pain and temperature, this is spinal lemniscus is affected, which is again lateral. And there is cerebellar sign, so spinocerebellar tract is affected, which is again lateral. And patient has got horn nuts on the left side, which would be due to sympathetic involvement, which is again lateral. So what is the diagnosis? Left lateral medullary syndrome. So this is also called Wallenbach syndrome. So this is the way we can localize in brainstem. This is a very accurate one. Now, if there is a situation where there is involvement of both medial and lateral structure, we should always think of basilar artery stroke, where both sides of the midline can be affected and both medial and lateral structure can be affected. So remember, if there is both medial and lateral where you can it's present, then always think of basilar artery involvement. Okay, thank you very much. I'll stop here.